just do Huntington the first Thursday of every month. So I just started in September, so I've just done one. I had 6 patients a couple of Thursdays ago, and 6 out of 6 had BMIs of 200% or more.
Oh my
I
God.
saw a 56-pound 2-year-old, an 85-pound 4-year-old, and I was like, wow. And all of them, I wasn't seeing them for oral health. All of them had terrible dentition. And I didn't realize, I mean, Carroll County, you don't think about that as, it's like Appalachia.
We don't think about how many of the world because I guarantee you where y'all go down to Shelbyville, you see the same thing.
Oh my goodness, yes, yes.
Is that close to Tullahoma?
Yeah.
Kinda.
Yeah.
Yeah,
Well,
kinda.
the reason I asked, UT Southern is one of the schools that's recruiting.
Because when we go,
and-
whenever I've been to Jack Daniels, sometimes we go through Shelbyville just because it's so beautiful.
We
you
need
know,
to
to
go
see
out
all the
UT
horse
Southern
farms and
School.
stuff.
Yes.
That's what I told her.
Oh,
And she's like, I don't live in Tullahoma. I'm like, that's a pretty cool little school.
It is a really cool little school.
But yeah, she wants to live in Murray, Kentucky. I'm like, what's the difference?
I'll tell you the interesting thing about UT Southern is that whole town is about UT
They
Southern.
still just
yeah.
chat.
I mean, it's all about
I
that.
bet.
How many people
That's
are
where
on?
Martin is.
Can you tell?
Oh, yeah. It's got a really cool.
Is that Jack back there?
Yeah.
The lights are in my eyes.
Yeah, it's Ballard back there. It's got a really cool.
For half a second, you look like Cameron Sexton. I'm like, what's speaking
Ah.
here?
Yeah. Oh crap! Yeah.
Yeah.
Let's see. Had to throw.
Mood just got worse.
Had thrown your whole day
Yeah, I
off.
know.
If that's
You started it.
I thought you'd gotten away from that
Yeah, I
crap.
thought I had too. Thought I had too.
Oh.
Well, maybe the donors are all getting real
They
friendly.
are. That's what I said. They're all chatting. I said they're going to be in a good mood.
That's good.
That is
good.
good.
Because we're going to talk about getting more of their money, aren't we?
I thought you were supposed to ask for money over alcohol.
Oh, I will. Don't you worry.
Tristella.
Tristella.
Oh my gosh.
Now I'm not going to be able to
Tristella's
hold a straight
strategies.
face.
Think about the drink. Yeah, I mean the beer, Stella.
Yeah, Tristella. I know, and I think about Natus, which is our organization
Stella.
for Natusty. Tristella! I mean, I won't say that.
I'm not going to be able to hold a straight face here. Y'all keep doing this.
Streetcar named Desire.
That was Marlon Brando, right?
Yeah,
We used to
in the
that-
movie.
That was our most fun thing during press conferences when somebody would give everybody a challenge, like you must work in this word.
Yeah.
And you could get, I mean, it'd be a crazy word. You might could get it in, but the challenge was doing it with a straight face and trying to do. And so that you could see everybody in the back of the room going, yeah.
We're going.
That's hilarious.
It didn't mean that.
Yeah.
It didn't even
Why
fit.
did she say that word? That didn't even make sense.
Did any of the reporters ever catch on that was
I don't
happening?
think so. I don't think so. I only got to be close with one, Blake Farmer, and sometimes I would tell him.
Yeah.
And he'd kind of laugh.
Re- okay, we're ready, y'all. Probably about 10 seconds away. Good morning, everybody. My name is Laura Faber, and I'll be moderating this meeting. Over the last several years, I have had the opportunity, working with Delta Dental of Tennessee, to see firsthand the difference a healthy smile can make. So throughout today's forum, we're going to be showing you some before and after pictures of people whose lives have been transformed because they had access to oral health care. I've met and heard about patients across Tennessee who were not able to get major organ transplants because of tooth decay, young mothers who never smiled at their children because of the condition of their teeth or lack of them, people who couldn't get a good paying job because they couldn't smile in an interview and covered their mouths when talking. When you hear about dental health, you mostly think of bright smiles. But when one has poor dental health, they often can't eat fresh vegetables or fruit without excruciating pain. Often, they resort to soft foods, which tend to be high carb, high sugar, and lead to further decay and worse, chronic diseases like diabetes, heart disease, and more. This impacts not only health, but it also has an impact on the economic prosperity for individuals. And access to care has a direct impact on the potential economic prosperity of a whole community. A company looking to relocate to an area wants to be assured that their employees are able to conveniently visit dentists close to work and home. Last year, a team of dedicated health professionals devoted many hours to developing a plan for the state of Tennessee to be able to address why we are ranked among the worst states for oral health, and develop plans for improving access to care in our beloved state. Doctors Phil Wank, Rhonda Switzer, Sheree Farmer-Dixon, and then Commissioner of Health Dr. Lisa Piercy worked with a number of their peers within state government, the private sector, charitable dental clinics, the state's dental schools, and more on the ideas that we're going to be talking about today. So let's dive in, should we? We're going to be starting with Dr. Lisa Piercy, and I want to give a little background, Dr. Piercy, before I ask you a question. Commissioner Lisa Piercy is a nationally recognized physician executive with an MD degree and an MBA. She has extensive experience across the healthcare ecosystem. She excels at organizational strategy and vision, as well as health policy, state and federal government relations, public health, licensing, regulation. In 2019, Dr. Piercy joined Governor Bill Lee's cabinet as the 14th Commissioner of Health for the state. One of her most significant contributions to her time in office was her leadership through the COVID-19 response as chairman of the governor's pandemic task force. Dr. Piercy resigned from her position in May of 2022, and she is now the founder and CEO of Tristella Strategies, where she brings her extensive healthcare expertise, broad public and private network, and passion to innovate and transform healthcare delivery. Dr. Piercy, thank you for being here.
Thank you, Laura.
You became a champion for oral healthcare for the state, even during everything that was going on during COVID. Why did this become a priority for you?
Well, thank you for having me today, and thank you for allowing me to share this story. The story actually started before the pandemic. Nobody really heard about it, didn't get much press until afterwards. But it started out as a very simple operational issue. So when I came in at the time of inauguration in January of 19, you know, you do what you do when anybody starts a new job, kind of do a landscape assessment. All right, where are the spots we need to focus on? And one of the things that rose to the top very quickly was staffing in our own public health dental clinics. So to give you a little lay of the land, the State Department of Health has 45 public health dental clinics across the state. The problem was that only 30 of the 45 even had the lights on, and most of the 30 were only operating 1 to 2 days a week. But yet we were getting all of these calls, and local providers were getting calls about needing help for these patients. And so one of the very first priorities in our first year in office was getting these clinics staffed. So, okay, all right, well, what's the problem? Why can't we get dentists here? And, you know, like everything, well, maybe we're just not paying enough. And that was part of the problem. But then when you start looking at it like, wait, there aren't enough dentists in this state, period. So we started digging into the shortage, and we were about 700 dentists short in the whole state. But the scariest part was that because some of our dentists are getting older, we're going to have we call a gray wave.
Yeah.
40% of practicing dentists in this state, or about 1,300 dentists, are due to retire in the next 10 years. So if you think it's bad now, it's about to get worse. So, we got to looking at it, and it's like, well, what are we going to do? Well, we need to provide the services at the state public health department that have to be done. And we are seeing about 30,000 visits a year, but it was pretty basic. Cleaning and extractions. Basically get you out of pain, and then you're kind of on your own. Maybe, we could get you to a safety net clinic or an FQHC, but most of the time they were just left out on their own. So that we identified the need. And then this pesky little problem called the pandemic came up after about a year. As you can imagine, all of that work was put on hold, and many dental practices across the nation were significantly reduced. So when the pandemic started its first inklings of waning back in the spring and summer of last year, so this was late spring, early summer of 21, we thought it was waning. It raised its head again. But we said, let's get back to work on this. We were all looking for something to work on outside of the pandemic anyway. This was a pressing need. But the other thing that had happened during that time frame is our friends over at TennCare said, yeah, we want to start working on this too. And so Governor said, y'all get together and figure out a solution. And it's just been sort of a career-long practice of mine. Sort of before inclusion was cool, it's that better outcomes happen when you have more stakeholders at the table representing different points of view. And so asked for permission to bring a multidisciplinary stakeholder group together for this dental work group, and said, what do we need to do? We need to find a comprehensive solution. So we got people like dental schools and payers and providers, the safety net, people in public health dentistry, as well as associations to represent not just dentists, but also hygienists and also providers at large. And in the spirit of a true public-private partnership, I was the public sector lead. We needed a private sector lead. So asked Dr. Wink to do that and represent on the private side, and he brought other stakeholders to the table. And we got to talking, and I kept hearing these statements being made of, this hasn't been done before. And I think I asked Dr. Farmer-Dixon, well, why hasn't this been done before? This is something that clearly needs to be done. And, the answer was pretty complicated, but it boiled down to, you have to be mindful of the needs of all of the different stakeholders. Unfortunately, it's not specific to Tennessee, but public-private partnerships oftentimes are very unbalanced or asymmetric, and it meets the needs of one and sort of placates the other one. But this is really, we all need to move our agenda forward. So when we pick that work back up, we had several meetings over the summer and into the fall, and then sort of produced some recommendations in the early part of the winter. So this would have been late 2021. And it had several components, the largest of which was increasing the dental class size. And Dr. Wink shared with me something that I thought was super interesting and informed some of the workforce shortages that we were having. And it was that when he graduated from dental school in the, I won't say,
last century.
I graduated in the last century too, so you're in good company. But that they were actually graduating 2 classes a year.
Yeah.
Well, then you can see that was about 40 years ago, and so now their retirement wave, and now the pipeline is half of what it used to be. It doesn't take a finance expert or a statistician to figure out that that's not sustainable, that that's not going to work. So our first and foremost priority was building the pipeline of dental professionals, specifically dentists, but also hygienists. The dentists can't work in isolation. So that was the primary component of the program, which we ultimately named the Healthy Smiles Initiative. And then it was, okay, well, what lessons can we learn from medicine, for example? Well, In medicine, what we have seen is that people like to go into high-paying subspecialties, and they like to go into urban and suburban areas where people are concentrated and commercially insured patients. They can get paid. That makes sense all day long. From a professional standpoint, it doesn't make sense, or it doesn't help those people in the rural communities who have little to no payer source, and there are less incentives for professionals to move to those kinds of areas. So we can put out all the dentists, by increasing the pipeline, but if we put them all into the wealthiest parts and the most dense parts of the state, that's not going to help solve the problem. So the second biggest component of that program is how do we recruit and retain a workforce in that rural area? So that was a big part. And then the third part was, how do we take care of people who have sort of fallen through the cracks? Sometimes we call those safety net patients without a payer source necessarily. Sometimes those are our elderly patients, or the patients who need something we call prosthodontics, which is a fancy word for dentures. And so how do we fund those programs? Now, fortunately, some of those programs had been funded through various state initiatives, but they were starting to come off of a cliff, right, or expire. And so we can't go backwards. We have to maintain that. And then finally, and I will admit, it was a little of a pipe dream initially, but then when you started putting the pieces together, like, remember what I said at the beginning, this takes all the pieces and we have to do them all, even if some of them are a big bite to chew, no pun intended, which was, we need TennCare coverage. Yeah. We need to add people to these TennCare rolls. That comes with a really big price tag. So when we added it all up, and got to the register, we got, even outside of the TennCare, we got to about $94 million. Mm-hmm. So that was great. We had this whole group put together. We had this beautiful report and this budget laid out, but it was just on paper. And so then we had to go to the General Assembly, because that is how, the executive branch gets funded. And so, first of all, I felt good going to the General Assembly, because this wasn't something that public health or a state agency had just come up with. I had private sector partners sitting next to me, literally sitting next to me, bringing this forward. And that brings a different level of attention when you have very revered and respected and successful private sector partners. So I brought it to the table, and never once did anybody say, oh, that's not important. The issue with all funding at a state level, whether it's governor's budget, and fortunately, because the governor had asked me to convene this, I got through the governor's budget pretty quickly, but that could have been a barrier, but it was not. Then we got to the General Assembly. It wasn't that it was a bad idea. Most bad ideas don't get there. It is that there's competition for funding. Right. There's a limited bucket, and I guarantee you, the governor and the General Assembly, if they had a magic wand or an unlimited bucket of money, they would have funded everything coming to them, or most everything, I should say. But they have to make choices and prioritize. So then the onus was on us to, how do we present this as this should be a top priority? And whether we really want to or not, it is one of those things where sometimes we have to overcome our own bias of, is this a cosmetic issue or is this a medical issue? Right. Because when we're really honest with ourselves, we say, for people like us who are oftentimes insured, and even if there's a substantial out-of-pocket, we can usually figure out a way to do that. We think of it as a cosmetic problem. We don't think of it as something that is going to be maybe perhaps even existential to our livelihood. So, when you first start talking about how do you convince people, well, I borrow a statement from Dr. Wink, is the mouth is actually part of the body. Right. And oral health leads to physical health. Mm-hmm. And as a physician, I've got a little bit of experience of talking about what are the downstream physical health effects of oral health. So that one's pretty easy to convince people of after you get over the cosmetic barrier or the luxury barrier. But then you start going into second order and third order issues. One of those being rural hospital sustainability. So that was where I was uniquely poised, because people were used to hearing me talk about the importance of keeping rural hospitals open. There was absolutely no direct correlation of how does that correlate with oral health. But then when you look at TennCare expenditures, that when these patients that I just referenced that we were barely meeting the emergency needs of, when they don't have access to that, they go to the emergency room. So TennCare was spending $10 million a year giving payments to ERs for this emergency treatment. And we can all agree, it's not a ding on the ER doctors, we can all agree that that's not the best place of care for a lot of different reasons. So not only is it TennCare expenditures, but then patients without insurance are going to these rural hospitals. They just have to eat that cost. Well, when they eat that cost, that hurts their finances to provide all medical care for patients. So there was that link, and then one further link that if you look at a little bit of political strategy and, in a Republican supermajority, but really important for anybody is the economic impact and the ability, as you referenced a minute ago, of these patients to get jobs. And I've said it 100 times, if you don't have a good smile, you're probably not working at the top of your proverbial license. You may not have a job at all. There might be some implicit bias in hiring practices when people don't have an adequate smile, but also you may self-select out. You may choose something that keeps you out of the limelight or keeps you out of a public-facing job because you don't have that security of a good smile. So fortunately, we were able to make those arguments pretty easily, and thankfully didn't have much pushback at all. So we were approved for the $94 million, but there are some short and long-term challenges that maybe we can talk about later with that funding.
Well, and I do want to talk about that. And just so everyone knows, we're in the first year of a 5-year pilot program. This is the Healthy Smiles Initiative, $94 million, which sounds like, wow, that should be like you're good. And that isn't the case, and we'll talk about that long-term and short-term later. But I do want to get to our next guest, who of course is Dr. Wenk, Dr. Phil Wenk, and let me do a little intro for you, Dr. Wenk, and then we'll get to you. But after a 20-year career in dentistry, Dr. Phil Wenk took the helm as the president and CEO of Delta Dental of Tennessee in 2000. Since then, he's earned a reputation as one of Tennessee's principal healthcare executives and led Delta Dental to become the state's largest dental benefits carrier. Over his career, Dr. Wenk has received numerous accolades, including being selected as one of the University of Tennessee's top 100 distinguished alumni. He's also been included in the Healthcare 100 and recently named a most admired CEO by the Nashville Business Journal. He's the board chair for Tennessee Performing Arts Center. He serves on the boards for St. Jude Children's Research Hospital, Church Health, and Monroe Carroll Jr. Children's Hospital at Vanderbilt. He also serves on the board of his alma mater, the University of Tennessee Health Science Center, where he attended the College of Dentistry. And Dr. Wenk, thank you for not only being here today, but really bringing everyone to the table. And that's my first question to you. You did help bring others to the table when Dr. Piercy was starting this initiative. Who was part of that process, and why did you feel like it was so important to have so many different voices at that table?
Well, I think Dr. Piercy said it very well. When she and I talked, and we had gotten to be friends even during the pandemic, as much as you could be, because we didn't know what we were doing. But the interesting thing that first started, Laura, was the idea that how do we get this message across? And the commissioner was talking about the way she looked at it from the state government. Fortunately, I have been allowed to provide leadership to our charitable arm called Smile 180. Mm-hmm. Smile 180 has about 30 working poor clinics across the state that we work with, that we contribute funds to, that do some. They do incredible work, and every time I go and they thank me, it's like, we didn't do anything but write a check. You guys are doing all the work. And so we have the opportunity to work with both of the dental schools, and this has been really great for us because we can connect with the young people coming up and really generate friends within the both leaderships, and that's been really important. But the thing we had to overcome first, Laura, was it's only dentistry. Mm-hmm. It's just teeth. And that's a frightening thought. because, as she said, these biases that exist. And I remember when we first went to the Hill and we were going to do a program that the state funds for dentures for these working poor. And let me just show you my own bias. I thought, well, the state agreed we'll give $300 for a denture. So one top, one bottom, that'd be $600. And so the clinics have said, well, why don't you let them make a contribution up front? And they said, well, how much? And I said, I don't know, pick a number, $100, just use that. And we can all bandy around $100 and say, okay. Well, what I found out was it took some of those people 6 months to save $100.
Yeah.
And then something would happen at 5 months where chutes and ladders, they'd go down the chute and they'd have to start over again. So with the help of the commissioner and that sort of thing, we've kind of reconditioned that program so that we could deliver the money up front, and Delta Dental does that. But it was one of those things that after she and I talked, what we agreed to, she would bring in the people she thought was most important from the state. She and I would talk about who else should be in the room. It was obvious that we needed the dental schools. It was obviously we needed leadership that Rhonda Switzer would apply, because Dr. Switzer is a leader in the Tennessee Charitable Care Network without question. So we needed this diverse set of voices in the room. We needed the payers. So we had the Tennessee Dental Association come in as representatives. We needed the hygienists that Dr. Piercy pointed out. We needed those diverse voices in the room to say, what if, what can we do? Even to the point that, we would talk in the room, could hygienists do more like a nurse practitioner can? Well, the problem is that's not the way their license is set up, and it creates a problem. In some states, the hygienists are allowed to do some more work beyond what they're allowed to do in Tennessee. And those are some things that may have to be worked out. Of course, the commissioner's not there for us to ask for help with, but it will be something that the truly will have to go through the licensing board and the approval of the dentists and those sort of things. But you can make specific claims, here's what we're going to need. But as we looked at the problem, and she and I had times when it was just kind of us talking on the phone or on the what if matters, the 94 million seems like this, like you said, a massive number. But then when you started going, well, how much goes in this pot and how much goes in that pot and how much are we going to do to help these people? The working poor clinics, the Tennessee Charitable Care Network group, they were receiving, I think, $32 or $36 for a patient that came in. Well, that is what's called an encounter, which is kind of a medical-ish term. Dentists don't do encounters. They do work, And so if you think about $32, you think, well, that seems like an adequate number. That won't even probably cover half their costs that they're going to have if they're going to do any service of any significance. And with working poor people, you don't have the luxury of saying, well, we'll get you back for 7 appointments. They don't have 7 appointment times. And if they did, they couldn't tell you when it's going to be. Right. So that was critical for us. And so one of the things that we worked with was, you think about, okay, let's say go from 32 to 100. Well, that doesn't sound like much, but it's millions of dollars over a 5-year period. And so there's a lot of things that had to be addressed and will continue to have to be addressed. And the one thing I think everybody at this panel would agree, and you said it very well, but we slide through it. This is a 5-year program. Well, there's no guarantee about second money. There's none. But the most important thing is when you get to the end of 5 years, you can't stop funding this program. It won't be 94 million, but it will have to be funded. So whatever increases you put in for the dental schools to grow, or whatever increases you put in for the clinics to receive more pay, the inevitability of it is that's going to have to continue. You can't stop that funding. So whoever the next governor and group of legislators are, we want this to be a point where there is a recurring amount in there. Now, whether or not that would be the same amount every year, but there needs to be a number that we need to develop somewhere probably in the mid-3rd year while the governor is still in place to say, can we get a recurring amount in there so that at least this is protected? Mm-hmm. So you needed somebody like the commissioner who because I'm one that said, well, just write us a check for $94 million and we'll get it all done. Well, they weren't going to do that. That wouldn't even make sense. But we needed her to break it down, to help us get to that point. We needed the experience of Dr. Switzer's knowledge broad-based knowledge of how working poor clinics work, because I don't have that. You know, I visit, I'm a dentist, I can go in and look at stuff, but you needed that business background that she brings to that table that's an entirely different table. So if you really think about it, there's a whole bunch of different voices in the room, and we had to discern where do we need to get the voices heard the most. And I think, did we do perfectly? I don't know that you'd ever say perfect, but I think we did darn good on where we were going. And then the other thing is the idea of expanding dental schools sounds really simple. You just build a bigger school. Well, where's that money come from? There's no money in $94 million to expand the size of Meharry or expand the size of UT College of Dentistry. There is for growing the faculty, and the faculty were underpaid, so we need to get more money to them so that people who choose to do that part, use that part of their training to train future leaders, would be there. So there's a lot of locations where this money needed to go. And so as you think about just the idea of growing a dental school, well, the first thing is you don't get them in and go, okay, we got them in and now they're dentists. No, it's 4 years.
Yeah.
It's 4 years. And so you can't fix this problem by growing the dental school. It takes 4 years to even start to get there. So it was just, you know, kind of a myriad of things that we tried to address and put together. And truly in the end, Laura, I was very happy with where we could. I don't think any of us would have expected we'd have gotten the $94 million. I don't think anybody would have expected. And really, in the end, it was really the commissioner selling it. Did we have people working, and the Tennessee Charitable Care Network was working the lobbies and the work in the halls, and we had, and remember, these clinics are from Bristol to Memphis, and unfortunately everywhere in between, and seem to be growing in number all the time because of what she said. There's just this demand. It's not a need, it is now a demand for this. I mean, it's that bad.
And it really, this works because you had every
Without
piece
question.
working together.
Yeah.
And I do, you know, I'll tell you, the class size, that's the statistic I hadn't heard before, that is just not sufficient enough to meet the growing population. We all know how Tennessee is growing.
Well, I'm not afraid to tell her when I graduated. Most of the people in this room weren't born then, but I graduated in 1977. There was 160 people that graduated from UT College of Dentistry in that year. I'm not sure, you probably know roughly what there was in Meharry. You weren't probably born then, but I mean, but the interesting thing about that is in that class of 160, probably 140 were Tennessee. Now there's a contractual arrangement with Arkansas that of the 100 kids that are in the one-year school, 20 of them are going to Arkansas by contract. So that's because that's extra funding,
Right.
out-of-state funding that they're collecting to offset their other costs. So in the growth patterns at University of Tennessee, we can use that. Meharry's a private school, so you don't have as much control on that, but at University of Tennessee, all that growth will be in-state students. And they'll grow to 130 students is the anticipation, but it takes about 3 years to even get to that point.
Yeah, that's not immediate. That doesn't mean they're working
we don't
and
even have
practicing.
faculty.
And this is where our next guest, thank you, Dr. Wank. Our next guest that we're going to talk to is Dean Farmer-Dixon, and we're going to get into this, but I need to do a little intro for you too, okay? Dr. Sheree Farmer-Dixon is originally from the Mississippi Delta and made her way to Nashville to attend the prestigious School of Dentistry at Meharry. Her initial plans to return home after college and to go into private practice took a sharp turn when she was offered an instructor position at Meharry, and the mother of two and lieutenant colonel in the United States Army Reserve carved an impressive professional path for herself, quickly moving up the academic ranks. And today she is the Dean of the College of Dentistry at Meharry. Dean Farmer-Dixon has overcome barriers in race, gender, and academia, becoming the third woman to head the School of Dentistry at Meharry Medical College. She remains one of a few select women to lead in the role as Dean of a superior dental program, and I love this statistic, that produces 40% of the nation's currently practicing African American dentists. Thank you for being here, Dean Farmer Dixon.
Thank you.
I want you to just talk about, we're talking about the shortage of students. How many students do you have at Meharry College of Dentistry? What are your expansion goals, and what needs to be done to get there?
Thank you so much for having me here. And our current class size is about 62 students per class. So we have a total enrollment now of about 310 students. We have 2 graduate programs, a general practice residency program that is 1 year, and then we have a 4-year oral surgery program. And when I was in dental school, over 30 years ago, the class size was about 50 students. So we've gradually, over time, increased the numbers. But is that enough? No, it's not. And we recognize that. And so we started 2 years ago looking at how can we increase the class size? How can we increase the number of individuals that we are graduating? And so this year we increased to 75 students. And so we have 75 students that are in our first year. Now we are a private institution, but traditionally and we consistently, we have a certain percentage of students that come from the state of Tennessee, and that's after graduation will remain in the state. In addition to that, of those students, and that's about 20% of our students, and then we have about 7% of our non-Tennessee residents who will still, after graduation, stay in the area. One of the unique things that we talk about, and that is a part of our mission, is training our students to go into those underserved areas. And so we make that a part of our curriculum. And that starts in year 1 because we believe we don't tell them about it and then expect that that's going to happen after 4 years. Mm-hmm. You make that a part of the training. And so working with community-based, having community-based education as a part of the curriculum, going into rural areas where we have set up satellite clinics, or we partner with Delta Dental to provide equipment and support so that we can have rural clinics, working with the safety net and the FQHCs so that our students can rotate and gain the experience, because that experience is not just about learning and understanding how to extract a tooth or do a cleaning or do a filling, but understanding those communities, mm-hmm. understanding the impact that they are making in those communities, the social determinants of health that contribute to what they're seeing, the positive and the negative, so that they are understanding the whole person and how what they are doing impacts them. And so the majority of our students, about 82% of them, after graduation, practice what we consider primary or general dentistry in underserved areas. And is that enough? It's a move in the right direction. But in order to train these individuals, you have to have the infrastructure. Mm-hmm. And what is that infrastructure? Just like when we all went to elementary school, we went to middle school, high school, you had to have teachers mm-hmm. to teach and to do the training. Healthcare and dentistry is no different. So you have to have trained faculty that do that. And so Dr. Piercy talked about the practitioners and the graying of the practitioners. Well, the same thing is happening in dental education. The average age of a faculty member is about 64 years old. And so you have faculty who are coming in. Many of them come in after they are transitioning from private practice, and they are not yet ready to totally retire and want to give back. But what is the longevity of those faculty? And then when you couple that with specialists, and how do you convince, for example, an oral surgeon who can make more in private practice than you can in dental education? So this is not just a challenge that's unique to Meharry, but to all dental schools, of having a shortage of faculty. So you can increase the class size, you can double it, you can triple it, but you have to have the people who are going to do the training and the adequate training. In an ideal situation, you want to have about a 1 to 5 faculty student ratio. And so that means that for us, we have approximately 92 faculty in total. Ideally, we want to double that so that we're not overtaxing the ones that we have, and we're able to provide that one-on-one individualized small group training that makes certain that the individuals that you're graduating have the quality skills and expertise that they need. And so how do you convince someone to come into academia and to train the next generation of healthcare professionals? It sounds very attractive, and people want to do that. But when you look at, well, I've been out of school even 10 years, I've still got a lot of student loan debt, because the average debt of a student coming out of dental school is about $300,000. And let me specify that is typically just from dental school. Wow. We're not talking about the debt that they may have coming from undergrad. And so when you think about, yes, when you go into dentistry, you can potentially have a lucrative career, but as stated, well, you've got to pay those loans back. And so to do that, you opt to go into those higher end specialties, to go into those urban areas where there is a large population. And that's where you want to practice. Well, when I'm talking to you about coming into education, giving back, many of them would love to do it, but they're trying to balance, I've got all of these loans, I want to start a family, and that's going to be, how do you balance and juggle those things? And so how do we create a situation and environment where we can incentivize them to come in, and not only come into education, but then to train in the areas and be in those underserved communities, as was mentioned. And so having faculty loan repayment as an option is a way that you help incentivize or encourage faculty to go, or dentists to come into the educational sector and provide the training for those individuals. And it helps to create a diverse faculty so that we're not creating the challenge of, well, you're interested, it's like a domino effect. Every few years we get a wave of individuals that are coming in because they've retired from their practice, they've been in practice 30 years, and so they're ready to do something else. And so again, that creates another wave of individuals with an average age of 60 plus, and how long are they going to be there? And so it's a constant recycling of the same thing. And so creating and thinking of opportunities and ways that you encourage younger healthcare professionals to come into academia to help create a stronger infrastructure, so that when we talk about increasing the workforce, having those individuals that will go into those rural areas, those underserved areas, you have the infrastructure in place to train those individuals who will create the workforce, and then you have opportunities to incentivize those graduates to go into those underserved areas. So it really is, it's like the pieces of a puzzle, and all of the pieces have to fit. Otherwise, it's a broken process.
You're just band-aiding.
You're just band-aiding it. It's
okay,
like having a beautiful car, and if the motor is bad and the tires are bad, it just looks pretty, but you have not fixed. You've not fixed the problem.
Well, I think Dr. Piercy said, when you started looking at how do you fix, why hasn't this ever been addressed? Well, I think the answer is complicated.
It is.
I mean,
it is. It's multi-level.
Many parts to it. And even, the training, to me, what strikes me, if you get students who are training, and that's part of their training in those rural communities, you may have some kids for whom that becomes a real passion.
Yes.
And that's where they're going to go. But, do you have the people to train them and get them in those areas to begin with? I mean, it just is, you all really, kudos to you for what you did with this Healthy Smiles initiative and talking all together. So, okay, thank you. We're going to circle back in a second with all of you, but I do want to get to our last guest. And you get an intro too, Dr. Switzer. Are you ready? Here we go. Dr. Rhonda Switzer Natesty has spent her entire dental career overseeing dental programs for the underserved. In previous roles, she was the head of dentistry at a fly-in health center in the subarctic location of Churchill, Manitoba, which is the polar bear capital of the world. Not many people can say that. She also worked as a staff dentist for the Department of Health in Hamilton, Bermuda, where she treated children of low-income families, people with mental disabilities, and people in nursing homes and prisons. In 1995, Dr. Switzer Natesty became the first employee of the Interfaith Dental Clinic in Nashville and has been in leadership ever since, now serving as the company's CEO. During her tenure, the clinic has grown, and I remember this, from a 2-year operation in the basement of a church to a 2-clinic, 26-chair facility caring for more than 3,000 patients last year alone. She was inducted into the International College of Dentists. That's an honor reserved for 3% of dentists worldwide. Dr. Switzer, thank you for being with us today too. Everyone has kind of mentioned you in Interfaith Dental. It's recognized as one of the leading charitable clinics in the state, leading clinics in the state and the country, serving as a model for many others. What role do you see clinics like Interfaith playing in this initiative that we're talking about today? And what do you need at the local level to ensure success?
Right. Well, first, you can probably all see on the camera, I've been smiling a lot more lately. And that's being able to work with these colleagues, just extraordinary passion and talents going into this initiative. And I was so honored to be asked to be part of it. And I think it's evident to everyone on the call that, you know, we all felt like just throwing money at the problem wasn't going to solve it. We needed real systems change and systems work, and that the problem is really complex, and that it starts very early with dental education and community building. You know, to share that the conversations in the room were difficult. We had to weigh out a lot of things, and there was a lot of varying interests, but I'm very optimistic about this, and this is the largest investment that I've seen in my career in something that, of course, I care deeply about. So Interfaith does have an important role to play in this initiative, along with the other, 18 faith-based and community clinics across the state that operate over 24 sites. For a perspective, that group had over 50,000 visits this past year, involving over 25,000 patients. And of course, the dental federally qualified health centers that exist too, similar in size and scope and what impact they can have. That group, we know the communities that we're in. We know them best. So we're going to also know, are some of these initiatives over time working, and being a check on that. Are we seeing some positive changes? We'll also be a lot of the places for students to do their rotations, and for residents to grow and learn, and to be able to show these young dentists what it's like to be in public health or to be in a rural practice, and encourage them to take that on as their vocations. We've been doing this work a long time, these groups, and can share the best practices with these students of cultural sensitivity and community building. And we're also an important link, Interfaith especially, with the private dentists, with having so many volunteers in bringing them along in understanding how to be a good Medicaid provider, for example, and how being part of the solutions and the role that they can play, and also all of our connections with the corporate world in encouraging them to advocate for continuation of this program going forward. Interfaith has also taken on an important role in continuing to lead the Smile on 65 Plus program. So this program was originally funded through the Senior Elder Trust, and that funding was expended. But it was so successful that it has been made part of this initiative for funding for the next 5 years. And again, it's just so vital that our older adults, that is growing in numbers every day across the state, as we all age, have the care that they desperately need. And we've also bitten off a piece of advancing the community dental health coordinator workforce. So the Smile on 65 Plus program has 6 of this type of dental professional working in it, and our plans through this grant as part of the initiative is to place more of those across the state and train them in that work. And these community dental health coordinators are 1 part navigator, 1 part educator, and really understand the dental landscape and helping remove barriers to the care that people all need. And I think that's going to be key as Medicaid dental rolls out, but also all the work of all the clinics and the students in the areas. I don't want to understate the magnitude of the problem. I know I sound very excited, but poverty rate in Tennessee, there's 1 million Tennesseans that live in poverty. At least 2 million, 2 times poverty, can't afford to go to private practice dentists or have dental insurance that is inadequate. And Medicaid expansion into dental is going to cover an additional 210,000 people. So that's really good. That's a good start, but it still leaves a lot of people out of care. Interfaith this past year saw 3,366 wonderful folks on their journey to help. And for each person that we saw, there was a $550 gap in what we need to provide their care. So Interfaith this coming year needs to raise $2 million just to open the door to continue the amount of services that it had done. So these charitable care clinics across the state have been able to exist because of wonderful funding from many on the call and from the Smile 180 Foundation. And it's been a huge challenge. It's been month to month for so many of us for many years. And in the public-private partnership realm, it was the public piece that was missing. So this is a really good start in this partnership. And to me, this is not the time to back down on investment, but time to invest more, because now there is this public backbone support and a system where we can scale and really meet the need and to the magnitude that it exists. But I don't want to give the impression that dollars are flowing directly into the clinics. As we explained, it's a very complex issue, and all the pieces need to be in place, from wonderful providers to facilities and the mentors and the staffing and the funding and the connections with the community.
Will you just quickly, because I'm going to go, I have a follow-up question, but explain what you mean by the gap, a $500, $550 gap with each patient. That means that that comes from reimbursement.
Right. So on average, we look at what the cost it is to help make someone well. And when we talk about wellness, it's you're pain-free, you're cavity-free, you are workplace ready with your wholeness, and you have the skills to look after your teeth for the future, and you can chew effectively. So that's a tall order.
Yeah.
But to do that for folks, most of our patients across the state in these clinics can contribute something, or they come with some other sort of funding, which may be the safety net pot or the denture fund or those kinds of things, but there's still a gap after all that. On average in our facility of $550 to be made up. So investment is important to make it work.
Yeah. Thank you for clarifying that. I do want to, I have a couple of follow-up questions for all of you, but I do want to tell the audience on the Zoom, we are open to taking questions. The guests are happy to take questions from you. If you just want to put those in the chat, we have a crew behind the scenes who are going to be funneling those questions to me, and we'll get them to the guests. So feel free, if you have a question, to put those in the chat, and we'll get to those before we get done. I do want to go to both Dr. Piercy and Dr. Wink for this next question, and we're talking about timelines, because there's some simultaneous timelines, it sounds like, that are happening. Can you help us, and both of you can kind of answer this together, help us understand what the goals are, both short-term and long-term, for what you're trying to do here?
So I go back to the concept of a public-private partnership. Governor and I both very strongly believe in the power of the private sector, and we believe that the appropriate role of government is to support and facilitate the private sector in doing things that they can't do, or to give them a little nudge to do what they want to do. And I truly believe that the private sector is where the innovation happens, and it's where the growth is going to happen. So in the short term, that public commitment has been made, and thanks to the governor and the General Assembly for approving that. So that kind of gives them the seed money, if you will, to get started. And there's other work going on in the in the public sector. I believe it was Dr. Wink that mentioned it about potential policy changes related to an expanded scope of practice, or being able to do different procedures in different settings or through different technologies. So that work on the public side continues. It's not like, well, here we go, here's your 94 million, go ahead and prosper. That work continues on the public side. Then it's really incumbent upon the private sector, myself included now, to start promoting that work and supporting that work. Dr. Switzer talked about the gap in safety net care, and somebody else mentioned something that I'll admit made me take a little pause initially, which is, as opposed to some government funding which is given in one tranche of a 5-year bucket, this is actually metered out year to year in order to ensure accountability. Because the last thing any of us wanted to do, either on the public side or the private side, is say, here's a big bucket of money, go do with it. And unfortunately, a lot of government programs are like that, and there's not that closed loop on the back end. But this one sort of makes you earn it from year to year, which means both of the partners, both on the public side and the private side, have to step forward together and do some of those hard things, and then with the goal of, after 4 or 5 years, let it go on its own in the private sector.
You know, one other thing, and I think we'd all agree, when Rhonda and the commissioner and I got together, one of the things we talked about is how do we get responsible reporting in, and who should get it? Well, the money from the state flows through the Department of Health. I mean, it had to go somewhere, and that's the logical place for it to go. And there will be things that the Department of Health is going to have to do because, as she mentioned, you know, we got half as many clinics as we have counties. So if you start right there, you know you've already got a shortage. So how would we measure progress? Well, we don't, to her point, the public side will be, how do we grow these up? What we envision, and I know the deans envision from both schools, is taking these, not only these undergraduate kids, because they can't work without a faculty person there, but developing what's called an AEGD program. That's a postgraduate program for kids who want to just work a little more before they go out into private practice, or they're waiting to find a place, or whatever it is. If you can develop those programs, which are funded through the federal government, no cost to a hospital, they go through hospitals, no charge to the hospitals. Hospitals actually make a little money on these. Suddenly you'd have this ability to create these local clinics, and I know that you have, is it 2 that you're planning, is that right?
Yes.
So 2 there. UT is planning to have one over a 5-year period that goes one from Memphis all the way to Bristol.
Wow.
So, or actually Kingsport, but I mean, so the intent is that these AEGD programs would be developed as clinics, but the best place they can work is to help Rhonda in her working poor clinic, because part of their curriculum is helping people in need. That's part of the construct of the curriculum. So if we place these appropriately, suddenly the clinics who are really a lot of these rural clinics are really having trouble finding a dentist. Suddenly you've created kind of a hub and spoke. I know we kind of gassed about that, but a hub and spoke concept. So the AEGDs become the hub, and the spokes go out to these working poor clinics who have absolute need across the state. I mean, the one thing they would tell you is we're open 2 days a week because we got one dentist that'll volunteer one day and another dentist will. But go in the rural areas where the number of dentists are going down, now you don't have anybody volunteering. So the whole idea is to have people, and Rhonda is an educator on top of what she didn't mention is, and you didn't mention, and whatever her bio is, she's an educator. She teaches people how to do this. And working in an environment like Rhonda works in is a different environment from working in private practice. I'll just tell you, it is. Because it's unpredictable and your appointments get broken because the person got sick or they don't have enough money or whatever. And so when I looked across the state, if we can develop these, expand these out, then suddenly you begin to develop this program that will feed these guys who need these working poor clinics, who need help. They need more dentists. And the one thing that I guess the dental schools are now under the idea of, I guess they're a little bit on the private side, a little bit on the public side. So they report now to the commissioner. Here's where we are. Here's what I'm doing in Meharry. Here's what we're doing, so that they have an accounting, and they know. And I have told them at the end of the year, you said you could be here. Show us you're going to get there. And so when we meet with the commissioner, the interim commissioner. When we meet with the interim commissioner, that's the one thing they're telling them. They can't know how many appointments Rhonda has. That money's going to be flowing from the state straight to her for those programs under the safety net, or Smile on 65, or the denture program. That's going to just flow. There's not going to be any regulation. What I will tell you is, it means more people are going to get served. And if we can expand this AEGD program and put kids with everybody's kid me, but I mean younger graduates, where they can actually go and not have to have a faculty member. Now suddenly you're feeding the program, and so the beast is starting to get beat down after a while. And so I think that there's a number of things, and again, it's going to take time. But I think the other thing, Laura, that it's really critical that you can go back to what she said about the $500 and something. I think the most critical thing is, even though you double or triple the encounter amount she gets, she's still way short on money.
Right.
Way short on money. So the other thing we have to say is if there isn't private funds flowing into these things, we're in trouble. Because these clinics are seeing the people that nobody else can see.
Yeah. And we go back to, is $94 million enough? Did we address that, Dr. Piercy? Like, people may think, okay, well, they're good, but how much really is needed?
It sounds like $94 million sounds like a lot. It is a lot of money. Let's be honest. But I think if I had turned the group loose and say, what's in your wish list, we would have been well into the 9 figures, and that still would have been somewhat short term. So it sounds like a lot of money, but it's something just to get them started. As I mentioned, it's just a little bit of seed funding to start that path. And again, getting public sector out of it, making it self-sustaining to where after 3 years, 4 years, ultimately 5 years, it is self-sustaining and doesn't rely on public funds or not much public funds anymore.
Yeah. And then, as all of you had mentioned, it's a combination of private and public. I mean, it is all of it that makes it work.
Laura, let me interject one thing. And we haven't spent enough time on the work of those people at these clinics. They're the most dedicated people you'll ever go visit. I mean, every time I visit them, and I do that at least twice a year, I feel better just for what they do. They are so excited about being open, and there's an opportunity for this. And once a year, we bring all of them together here in Nashville and let them. Mostly, I think they learn more from each other than they'd ever learn from some person we could have do lectures or anything like that. And you've got leaders like Rhonda that can say, here's the way we do this. Well, there's a working poor clinic in this state that 2 women started because they won a little bit of the lottery, and they put all that money into running a working poor clinic.
That's awesome.
So.
Listen, I've been at Interfaith and some of your other charitable clinics across the state, and I can attest to how wonderful. I mean, it just is amazing, and you do feel better when you walk out. And I didn't even do anything except for interview the people. So there you go. Okay, I have a follow-up for both Dr. Switzer and Dean Farmer-Dixon. Can you both kind of address some of the challenges related to equity in the dental profession? I know we kind of touched on it a little bit, but is there any more that you can say about that? What are the differences, especially urban versus rural?
Go ahead.
I think there is certainly a difference. When you think about in the rural areas, and as was mentioned earlier, rural communities have limited access to care. And as a result of that, it's kind of, again, I use the word domino a lot, but it's a domino effect because having limited access to care, then limited access to resources and to services. And so what we have seen, and I'll use the clinic that we have in Shelbyville.
And we have some before and after pictures from this Shelbyville clinic too, Dean Farmer Dixon.
We have made, it has been eye-opening, I think, for the students, but it's been eye-opening for the community to have the service. But that is, to me, a great example of how public and private working together. The city provided the space, Delta Dental provided the equipment, we came in and we're providing the services. And to see this community, this is a community that has a great need, and the neglect that is there is not because they are just not wanting to take care of their teeth, but these are working people who unfortunately don't have dental insurance. They can't afford it. So for us to be able to go in and provide those services, and working with this being a safety net clinic and having resources to be able to provide those services for them, is what happens and the impact that you can make when you have partnerships that go across lines that all have the common goal and the common theme of how do we make a difference and make an impact in this community, not just go in and do a screening and say, oh, you have missing teeth. Well, they typically know that, but it's how do you treat that? How do you help those people have that healthy smile so that they are ready for the workforce? And when and that's just one example of what you see in the rural communities, or even in some areas where I'm glad there's going to be Medicaid expansion that will help offset that. But the other part of that, it goes back to having providers in those areas who will accept TennCare, and there in some counties where there may be one provider or a few providers there, but then they don't, the people still don't have access, because even if they have coverage, those providers are not accepting those coverages. And so in urban areas, you have a thicker population, but there's still, even in the urban areas, they're going to be you're still going to have low income, underserved communities that still don't have access. So the access issue goes across both lines of both rural communities and urban communities. Dr. Wink was mentioning about the communities, and Dr. Piercy also mentioned about having some clinics where the lights are off because they don't have a provider. Part of the expansion that we're doing is also expanding the number of residents and increasing those numbers, and strategically identifying, partnering with the health department, identifying counties where there was a great need and a lack of access. And so through these partnerships and through this healthy initiative, we will be able to go into those community health centers, turn the lights on, have our residents to go into those communities and receive training, but more importantly, are providing a service to those communities.
Dr. Switzer, anything to add about that?
Well, I mean, it's an inequity that shows on people's face. It's pretty evident. And
again, we have lots of photos
right.
that you guys aren't seeing these, but the
right.
audience is seeing before and after photos of lives that are transformed when this all works.
Well, and it's a cycle where you need teeth to get the job, but you need the job to pay for the teeth, and that's the cycle that unwinds. So,
Rhonda, I think people, it's easy to look at the rural areas because we know counties in Tennessee, take the larger counties, Davidson, Williamson, those counties, Chattanooga, Memphis, but there's in the inner cities, and we're not talking about the Gulch. I'm talking about the true inner city. There's a massive challenge for need there, because when Dean Farmer Dixon was talking about, people moving back to the areas of high population, they don't move into the inner city.
Right.
They move where they're going to be, with people more their age and people with a socioeconomic situation that will help them pay their loans off and let them live a lifestyle they want to live. So a lot of the people that Rhonda would get at her clinic, it's not just people coming in from Carroll County or some rural county. she's got a whole lot of patients who probably don't live but a mile away from her office.
Right. Right. This has been a great discussion. Again, if anyone in the audience has some questions, just put those in chat. Excuse me. We'll get those to the guests. But Dr. Wank, I do want to circle back to you. This is kind of, we need a call to action here. Excuse me. What is needed statewide to ensure the continuation of the initiative?
To ensure the continuation of the initiative before you started choking, I think is what you were saying. So I want to make sure we had that. And it is kind of a daunting task because, we're kind of a one and done society. How much I paid it off, and so I don't need to pay anymore. When I started the discussion, one of the things I said was, whatever money is in the last year of money, it just needs to keep running. You can't stop that. So we need the legislature, and we need whoever's going to replace this great commissioner we had, whoever's going to replace that person, to embrace dentistry the way she did. It can't just be, it's just dentistry. It has to be a recognized part of the health department. She took over a department that basically said, it's just dentistry. I mean, really, I don't know who they were, but I mean, there hadn't been anything done, or you wouldn't have all these closed dental clinics. And the number of clinics wouldn't have grown. I mean, when we started giving money to the clinics, I thought there was probably 5 or 6. And then I found out there's a lot more than that. And so I think we need donors that are committed and understand you can die from an abscess tooth. You can, it's happened. But the worst thing is you change lives when you do what we do and what we're trying to do. So the donors have to stay out there. And I think they have to say, and again, I don't want to understate, because I'm on so many boards I can't remember, I don't want to understate any of what they do. But for us, the passion is really in health. And this is a health issue, and it's a health issue that we specifically have to continue to support. And it's not just the state. The state has to bite their part, and they should do their part. But more importantly, we got to expand the donor base. You got to continue to expand, because even if you get a dentist that's an AEGD and we raise the money to $150, she's still $350 behind on that service. And so it's not going to get better. It's going to get worse. And the population is going to grow before we can get any of these dentists out. I mean, the population of Nashville alone would probably cover the number of dentists that we're adding. So think about those, and I'm talking about the MSA of Nashville, but it's not going to fix itself. And so we need that. We need legislative support. We need legislative leaders who support it. We need the health department, Department of Health to have it as a critical radar item. And then we need donors. We need more donors who take a trip to Rhonda's place. Right. If you take a trip to Rhonda's place, you'll write a check. I will just tell you, you'll write a check. And so I think those are the kind of things that we really need. And I'd like to see more companies that do what we do committing more money to that. I don't see them doing what they should do, in my opinion. It's one thing to say you sell health insurance, but if you're not giving back to the communities, I don't think you should have a license, but I can't do that. That take competitors out. So, but I mean, I think it's unfortunate when you don't see that group who should be espousing health, but they only espouse health to the people they take care of. They don't espouse, if you're a covered life, we espouse health. If we don't care. Well, that's wrong. So I think it's ideal if we continue, but it's going to have to grow. Yeah. It cannot get. We can't stop at the end of 5 years and say we fixed it, because it's not fixed.
This is why we're here today, talking to this group of people. We do have a question from someone in the audience. Miranda, did you already get that off of your whiteboard? This was for Dean Farmer Dixon. And this question wants you to share about cultural competencies, providers who look like me. Can you address that at all?
Yeah, there have been studies that have been done. The ADA has done one that says that patients are more likely and more comfortable with going to a provider who looks like them, who understands their culture. There are cultural differences, and there are different cultural philosophies. And so to go in and tell someone that, you need to try and save your teeth, well, if they're in their culture, in their family, it's been a generational thing where My grandmother lost all of her teeth. My grandfather lost all that. That is just a natural thing. And so being able to see someone who looks like them and who comes from an area where they've come from. So being strategic about going to rural communities and identifying and mentoring individuals in those communities so that they're more likely to go back to those communities or to communities like that to provide. I'm from a rural area in Mississippi. Fortunately, it was a black dentist from Meharry that I saw practicing in the community. So my passion is public health. And while I'm not back in Mississippi, obviously, but my passion is to work in those underserved communities because I know I experienced the need that was there and what was wanted. And so for me, it's important to work in communities like that. And so for black kids to see and black females to see a black woman who has come from a rural area, who has gone to school, who is doing that, and that gives them the opportunity to say, you know what, maybe I can do that too. And so I think it is important, especially in people of color, to be able to see people who look like them doing something that they can possibly conceive themselves of doing.
Right.
Laura, can I add to that?
Yeah.
First of all, it reminds me how great of a public servant you are, including serving our nation, so thank you for doing that. But you referenced it, and Laura, I think you mentioned it earlier about rural people going, rural citizens going back to that area.
Right.
We know from a workforce development and recruitment standpoint that the most successful rural professionals, whether that's doctors or dentists or whatever, are people who come from that area. And you mentioned it earlier, there are students who rotate in those types of areas. They may have grown up in an urban area and they just get bitten by the bug and they love it and they love staying in the rural areas, and that certainly does happen, and we're happy when that happens. But the highest yield is when you take students from rural areas and support them through their education and return them to their communities. And there's usually a magic number between 3 and 4 years. If you can get them to stay in that community, they'll put roots down and they'll stay. And not only does that help serve the need, but it helps take rural and sometimes underprivileged kids and put them on a trajectory where they'll be successful.
Right. Right.
One other thing I want to interject, because I know you've got another question, but in the rural and the urban areas, and I think that especially would address any person of color, but any person who grows up in an area of poverty, is to say to those young people, you can be what we are. You don't have to be what anybody around you is. We sponsor a program that was started by a dentist in Memphis, and it's called Determined to Be a Doctor Someday. And she basically has a program where she brings middle school kids in and starts mentoring them, and it grows. So there's one, there's an 8th grade group and a 9th grade group, and it goes all the way through high school. And they actually have a white coat ceremony, which all of us recognize as that's when you move into the clinics.
That's right.
And so it's really cool, but that's the other thing we need to do is education. We have to remind people you don't have to be what you think somebody or what somebody else thinks you should be. You can be what you want to be. You got to work, but you can.
Yeah, there's so many facets to all of this. It feels overwhelming a little bit. And one of the questions kind of has to do with this, and all of you have sort of touched on this, but someone in the audience had a question: what do we do to increase the likelihood that funding will continue and grow after 5 years? I know that this has been touched on, but does anyone want to have an idea about that? Something they want to add about that?
I'd start with her because she's going to know what.
Dr. Piercy's nodding her head. And we have about 15 minutes left in the forum, just so you know. But go ahead, Dr. Piercy.
As Facebook says, it's complicated.
Yeah.
And just as we talked about how complicated it was to get to this point,
Right.
It's not going to be easy to move forward. But what we can do is start now. And I referenced earlier sort of the contribution, both proverbial and literal, from the private sector in doing that. But it's also thinking about things differently. And we all like to sometimes put the pandemic out of our minds, but there are some good things that happened. There are innovations that took hold during the pandemic that, because out of necessity, that we can leverage and grow. So I'm just kind of throwing out ideas here. How do we use innovation and technology to deliver services to people more efficiently, faster, cheaper, or to reach people that haven't been reached? There are some people who physically cannot come to the dentist. Older people in facilities, people with disabilities. So how do we leverage technology to do that? Well, unfortunately, many of our laws and rules, as it were, licensing rules, are written that doesn't allow for that. So do we need to get creative on that? And do we need to push the envelope? And so start doing things, and I hate to use the cliche, but working smarter, not necessarily harder, at least not harder in the way that we've been doing it. And then setting up these sustainable streams of funding with both public and private funds, where this is never going to be, and healthcare and dentistry and all of those things are never going to be a purely private sector thing. That model just doesn't work. But neither does a full public sector either.
Right,
and so you have to come together, and where do we need a little push to get the ball rolling and create that sustainability? And that's why we're poised very well right now in this first year and almost heading into the second year of this program. Okay, we've got our feet underneath us now, and now how do we set this up to be self-sustaining? How can she grow her student population in a method to where tuition starts paying for some of that faculty? How can Dr. Switzer grow her patient population and set that up in a format to where there is a little skin in the game for the working poor, but it doesn't create a barrier like Dr. Wink talked about? So again, don't want to sound too cliche. Now's the time for action. I tell you when is not the time for action, at the 4.5 or 5 year mark.
That's right.
It's right now.
I really think, as I said early, starting on is by the time we get to start of year 3, you better start looking what your next strategy is. What worked, what falls short. You know, we were happy when we asked for $100. At first we didn't even ask for $100, but we got to $100 for encounters. And now is that, if you take the 550, that's not going to be, it's still short. So how do you do that? How do you do those things? I think you do the progress reports on the first year, and that includes the clinics saying we've been able to see more patients because of X, more money or whatever it is. So that shows that whatever you gave us worked in the first year. They continue, the dental schools continue to say, we're growing our faculty, we're doing this, we're doing these things, we're building these AEGD programs, so those things are happening. But you're going to need to get into the second year before you have the funding to do some of those things. So really, we got the car started, it's kind of rolling a little bit. It's going to take to get to the third year to really see this come to fruition or begin to come to some level of fruition. And one of the things that the commissioner didn't mention that is in there is, okay, you got this place and you pick it out and it's in a rural area XYZ, and she mentioned 3 to 4 years time. Well, in this deal, there's a payback program for a young person who would go in to a chosen place that needs a dentist. It could be inner city, it could be in a rural area, and it pays up to $300,000 of their debt off.
Wow.
So there's an incentive. Now you got to stay. You can't take the money and then run. But there's an incentive.
Speaking of incentives, we have another question, and we're probably getting close to, we're kind of winding down, but I like this question and would like to get it in. I think Dean Farmer-Dixon, you talked about this, but how do you get providers to provide services to TennCare children and adults? How do you encourage that? And is that a challenge? Is that something that this is another part of that, of the vehicle? We keep referencing cars, and if the tires aren't good, it just looks pretty.
Ron will have some answers. Let me give you my side of that. I think you have to direct it more the way private practice is. Their method, the method that's set up is conceptually, to me, not, it's based on, this is enough dentists to cover this. This is our panel, and we don't take more into the panel. Well, if I know how many patients I have, and I go, okay, and I know how much money I have to spend, I should be at 65 or 70% of the children in the state covered. They're at less than 50 after, I don't know how many years of TennCare has been in place. And we've been involved in it too, and it's a very difficult process. But it needs to be looked at again, because the idea of saving money and fixing these problems, they don't work hand in hand. And if you went to a more practice like it is in private practice, where you could take 10 care kids a week, or you could take 100 10 care patients a week. But you can't have the rules and regulations, because the dentists go, I don't care how much you're going to pay me, I'm not going to do that.
Right.
So their rules and regulations, to me, are far beyond justifiable. I know they have restrictions, I know they've got federal controls and that sort of thing, but you're going to have to change the model. And if you don't change the model and you say we're saving money, you should never save money. You should treat more kids. Yeah. I wanted you to spend it all on treating kids. So Rhonda, that's your turn.
Well, I think that it's bringing the two parties together to say what they need. And I think there's a lot of misconceptions on both sides of how it works. A lot of dentists I talk to just not understanding how it works and what rules are in place and for what reasons, and how you can work within that framework. But I think there needs to be more forums of the two groups together to figure it out going forward, because especially with adult coverage happening, I'm not hearing a lot of people saying they're wanting to take on adult patients, and they're asking questions to me like, well, are the no-show rates higher? Those kinds of things, and how do you manage that? Well, let's talk about some ways you might be able to manage that, because that is a reality for a lot of people that don't have reliable transportation and childcare, et cetera. So,
or funding, or their own funds.
Right.
Yeah. So, but I think you're going to have to look at the model, and I don't think has been as well. I don't think the provider side has been represented as well as it should be.
I think it has to be kind of similar to with this healthy initiative, and it's bringing in the key stakeholders, and as you said, looking at the model, but who is it that's looking at the model, and making certain that everyone who's impacted by it, even the community, is at the table as we discuss if you're really going to make a difference. Yes, it's making an impact, but is it really meeting all of the patients' needs, all of the community? And right now it's not.
And what I'm hearing everybody say is this is a long-term play.
Right.
It is.
This is not a one and done, and this is iterative and incremental change, and we have to commit to the long term. And so it's one of those things that I'm glad we're working with friends, because we're going to be doing it a long time.
Absolutely.
Right. And I think have to be willing to have that debate, and differing opinions on how you get there, and it's not just I think you said this, it was kind of a Star Trek reference, Dr. Piercy, but you said, here's 94 million, go forward and prosper, that's not the end of it at all. Okay, we have about 2.5 minutes left, so I would love every one of you just to get a quick 30 seconds, just a final thought of what you might want to say to this audience, the Middle Tennessee Donors Forum, who's been with us this morning. Dr. Switzer, just a final thought for them.
I probably know most of the people on the call, so just thank you for your time being with us this morning and helping to understand the complexity of it. And I hope you will help celebrate my 3 colleagues as well on their work in doing this.
Thank you.
Thank you, and this is the beginning of one of many conversations, robust conversations, because it's going to take all of us working together to really push this initiative beyond the 5 years so that it does continue and it is sustained.
Thank you.
I recognize it's probably unusual to hear a medical doctor talk about dentistry, but as I have learned, the mouth is part of the body, and the teeth, in all seriousness, oral health does impact physical health. So when you look at the health not only of individuals, but the health of Tennessee, even the economic prosperity of Tennessee, oral health is a key component.
And it's an economic saver for the state of Tennessee too. One of the things that Dr. Piercy shared with me, if you have dentistry and you could treat a patient or send that patient to the right place and they don't go to the ER, that ER visit just to give them medication is $700. Wow. $700. There are thousands of those every single day.
Wow. One thing I learned when I first started doing stories at some of the charitable clinics that Delta Dental helps provide equipment for, et cetera, was that the mouth, everything starts with the mouth. So you can't, so when it comes to medical procedures, you're not moving forward on anything until you get your mouth fixed. And then the whole economic prosperity for not only the individual, but the community at large. I mean, it just is, when you start really diving in and peeling back those layers, you realize what a complex task you all have agreed to take on voluntarily. And so I appreciate that as a Tennessean myself. So, okay, I think that we're done. I want to thank all of you. It's been a pleasure to be with you this morning and just to really hear your thoughts in that process of how the Healthy Smiles Initiative even started, and what the legislature did, and what needs to be done going forward. Thank you, everybody out there on this Zoom call from the Middle Tennessee Donors Forum, for being with us and hanging with us for this hour and a half. I hope that it was informational for you and you got your questions answered, and that you help this group move forward and prosper.
That's right. Thank
In
you,
the
Laura.
future.
You did a great
Thank
job
you.
for us.
And I think we're done. And I hope everyone has a great rest of the day and week. Thank you so much for being with us.
Thank you.